Welcome to today's Explainer. We are jumping right into a phenotype to synapse deep dive into the somatic and functional neuromodulation matrix. If you deal with idiopathic or complex physical symptoms, you know exactly how incredibly frustrating it can be when the physiology seems completely invisible. Well, today, we're making the invisible visible. So here is our foundational matrix. And right off the bat, we are shifting entirely away from vague psychological labels. We're moving strictly into circuitry level, brain medicine realities. We're going to be exhaustively covering 6 distinct phenotypes today. We've got the sensitized, the enteric, aberrant salience, the ectopic or FND phenotype, the affective somatic, and finally, the psychomotor phenotype. And here's the key. Each one of these has a highly specific clinical presentation, an exact underlying circuitry error, and targeted pharmacotherapy. Here's our quick roadmap for today's deep dive. 1. Sensory and autonomic dysregulation. 2. Aberrant salience. 3. Ectopic networks and functional neurological disorder. And 4. Affective and psychomotor phenotypes. Let's get into it. Starting right off with Section 1, Sensory and Autonomic Dysregulation, we'll be examining the sensitized and enteric phenotypes. Okay, think about the precise clinical presentation of the sensitized phenotype for a second. This absolutely isn't just generic pain. What's happening is the brain's sensory volume dial is literally stuck at maximum. We're looking at widespread aching, hyperalgesia, where even mildly painful stimuli become totally agonizing, tactile allodynia, where just the brush of a soft shirt against the skin actively hurts, and severe somatic insomnia. We really need to unpack every single one of these symptoms as a strict sensory processing error. So what's actually happening biologically? It's a neurobiological cascade called descending inhibitory failure and central sensitization. In step 1, we see a critical depletion of serotonin and norepinephrine, 5-HT and NE, specifically down in the dorsal horn of the spinal cord. Because the brain can no longer inhibit incoming signals, step 2 kicks in. The nervous system actually upregulates presynaptic voltage-gated calcium channels, specifically the alpha-2 delta subunit. And this structural change directly forces step 3, which is a massive, totally unregulated release of excitatory neurotransmitters, specifically glutamate and substance P. The sensory gates are just stuck wide open. Now, here is the crucial part, mapping our pharmacology directly to that exact circuitry. Our primary pharmacological foundation relies on an SNRI, specifically duloxetine at 60 to 90 milligrams. Why? To correct that dorsal horn depletion of serotonin and norepinephrine. But for augmentation, we use gabapentinoids like pregabalin at 75 to 300 milligrams. This is because they directly block that excessive calcium influx at those upregulated alpha-2 delta subunits we just talked about. Hit the nail right on the head. And for truly refractory cases, we can actually introduce direct D2/D3 agonists like pramipexole to force descending modulation. Next up, let's shift to the enteric phenotype. These patients present with profound gastrointestinal distress, right? Functional dyspepsia, severe somatic nausea, and intense irritable bowel presentations. But as we're going to see, these GI presentations are actually severe brain-gut axis dysregulations. This system breaks down in 3 steps. Step 1 is presynaptic D2 receptor hypersensitivity, happening right there in the gut. This peripheral error combines in step 2 with vagal nerve dysregulation, sending completely chaotic, amplified signals straight up to the brain. Finally, in step 3, we see specific interoceptive mapping errors. The insular cortex, which, remember, is the brain's main interoceptive mapping center for internal body sensations, becomes severely hyperreactive. The brain literally feels the normal, everyday digestion process as a painful emergency. This perfectly illustrates why our pharmacological approach has to be incredibly precise. The primary intervention relies on low-dose atypical D2 antagonists, like amisulpride at 50 milligrams or levocilpridin. By using a very low dose, these specifically target those hypersensitive presynaptic autoreceptors to actually boost localized GI dopamine and restore normal motility. Pretty amazing, right? Adjunctive treatment utilizes mirtazapine, carefully selected for its highly potent 5-H3 receptor blockade, which directly shuts down those severe somatic nausea pathways. Moving right along to Section 2, Aberrant Salience. Let's look at the neurobiology of hypervigilance and symptom checking. These symptoms, severe health anxiety, constant compulsive symptom checking, and a catastrophic misinterpretation of normal physiology, they're so often frustratingly dismissed as someone just being a hypochondriac. But it is absolutely vital we reframe this. These aren't just mere worries. This is a rigid, structural, biological tagging error happening deep in the brain. To really understand it, we rigorously define the core mechanism here: predictive coding failure. This is a severe circuitry error where the brain completely loses its ability to filter incoming data. It falsely interprets completely benign interoceptive signals, like a normal heartbeat or a slight muscle twitch, as a high-threat, critical danger. This failure locks a specific brain region, the anterior cingulate cortex, or ACC, into an alarming, hypervigilant feedback loop. It's essentially a faulty smoke detector that goes off just because you boiled water, locking the brain into a state of continuous emergency. Let's trace that exact pathway. In step 1, the ventral tegmental area, or VTA, inappropriately fires and falsely tags those benign bodily signals with intense emotional salience. It rings the alarm bell for literally no reason. In step 2, because of that failed predictive coding we just discussed, the anterior cingulate cortex can't turn the alarm off. The ACC is now locked into sustained hypervigilance, forcing the patient to obsessively monitor their body. So how do we shut off this false alarm? The primary track requires pushing high-dose SSRIs, like escitalopram or fluoxetine, to flood and downregulate the anxious circuitry. But when that isn't enough, we augment with very low-dose D2 partial agonists, specifically aripiprazole at just 1 to 2 milligrams. At this microdose, aripiprazole acts as a highly specific circuit balancer. It's perfectly poised to antagonize those hyperactive mesolimbic tracts firing out of the VTA without crushing the patient's overall dopamine system. All right, Section 3, Ectopic Networks and FND. Let's unpack functional tremors and paroxysmal pain. Now, with the ectopic or FND phenotype, we are dealing with incredibly jarring symptoms. Patients report sharp, paroxysmal electric pains that just shoot out of nowhere. They present with localized functional tremors and highly disturbing neuropathic paresthesias. I really want to emphasize the paroxysmal, unprovoked, electric nature of these specific functional symptoms. They don't build slowly, they strike. Why do these symptoms strike so violently? It all comes down to a phenomenon called ectopic firing. Due to long-term sensitization or trauma, the nerves actually begin expressing completely abnormal densities of voltage-gated sodium channels right along their axons. These clustered sodium channels become highly unstable and cause spontaneous nerve discharges, triggering massive, unprovoked electrical signals out of absolutely nowhere. And here is how that rogue electricity totally hijacks the brain's motor system. In step 1, those abnormal sodium channel densities cause the spontaneous ectopic firing, just blasting the brain with sensory noise. In step 2, this intense sensory threat couples with a hyperactive fear center, resulting in the amygdala literally hijacking the supplementary motor area, or SMA. The emotional center of the brain essentially overwrites voluntary motor control, and that's what results in those functional tremors and spasms. To quiet this system down, we have to target the rogue electricity right at the source. The primary intervention relies on sodium channel blockers, specifically oxcarbazepine, to stabilize those abnormal nerve densities and halt the ectopic firing entirely. But listen, it is absolutely vital to note the caution here. Oxcarbazepine is strictly preferred over carbamazepine. Why? Because carbamazepine aggressively induces liver enzymes, which would totally destroy the CYP450 metabolism of the patient's baseline SNRI antidepressants. Oxcarbazepine protects that metabolism while still blocking the sodium channels. I also really want to emphasize this pivotal clinical guideline. For any clinicians out there treating functional neurological disorder, you must understand that the motor symptoms, the tremors, the hijacking of the SMA primarily require specialized neurophysiotherapy to retrain the brain's motor pathways. We are using these potent medications strictly to target the comorbid sensory pain and silence the ectopic firing, not to magically cure the tremor itself. Finally, Section 4. Affective and psychomotor phenotypes. We're looking at glutamatergic excitability and hypodopaminergia. Let's fiercely contrast our final two phenotypes. The affective somatic phenotype presents with pain that violently flares with emotional distress, highly labile mood, and sometimes even borderline personality traits. The circuitry here is profound HPA axis dysregulation, driving excessive toxic glutamatergic tone simultaneously across both the limbic and somasensory networks. Basically, the brain is on fire with excitability. In stark contrast, the psychomotor or fatigue phenotype suffers profound functional exhaustion, heavy limbs, and intense brain fog that masks as a neurological deficit. This isn't glutamatergic hyperexcitability, no. This is prefrontal striatal hypodopaminergia. Chronic neuroinflammation and cytokine spikes, which are often secondary to hypocortisolism, are actively inhibiting dopamine synthesis in the striatum and prefrontal cortex. The brain is literally starved of dopamine due to inflammation. And this beautifully illustrates why our treatments have to radically diverge based on the exact phenotype. For the effective phenotype, we build on an SNRI or SSRI foundation, but we specifically augment with glutamate modulators, like lamotrigine, titrated very slowly. This directly decreases that global excitatory tone in both the cortex and spinal cord. Conversely, for the psychomotor phenotype, we must restore the depleted dopamine. Our primary tool is an NDRI, specifically bupropion. It inhibits the DAT and NET transporters to trap and restore dopamine right in the prefrontal cortex. However, you must carefully note the contraindication here. Bupropion is strictly contraindicated if the patient has comorbid high baseline anxiety or a history of seizures, as it lowers the seizure threshold. We have covered an immense amount of rigorous neurobiology today, haven't we? So I want to leave you with this final provocative thought. How will recognizing predictive coding failures and ectopic firing permanently change our approach to idiopathic somatic symptoms? Think about it. Once we realize that these mysterious symptoms are actually strict circuitry-level errors in calcium and sodium channels, dopamine synthesis, and ACC hypervigilance, we can never, ever go back to telling patients it's all in your head. We are equipped to fix the circuits. Thank you so much for joining me for this explainer, and I really hope you take these insights directly into your practice.